Ai, meu Deus. Deu pouco ruim aqui. Deixa eu ver aqui.
Ah, não, tá hoje não, né? Não, não tá hoje não, né? Isso, foi.
So, can we start?
Yeah, sure. Thank you.
So, my name is Jade Gomes Ferreira. I am a first-year general surgery resident. We speak from Brasília, Distrito Federal, and we are in Hospital de Base do Distrito Federal. Today, we are talking about blunt abdominal and thoracic trauma. So these were the staffs that were with us receiving this patient that we are going to present. And talking a little bit about our hospital resources. Our emergency department, we have an ultrasound, we have an X-ray, arterial blood gas, and blood bank, and the CT scans. So moving on to the case. The admission. So LMRF, female, 60 years. She was brought to the service by the pre-hospital rescue unit after being run over by a car. She was classified as yellow in the Manchester triage system, so she was considered urgent. She referred dyspnea, pain in the left arm and in the left leg, and she denied abdominal pain or any abdominal symptoms. So on her physical exam, she had she had pain airway. She was with the cervical collar, but without cervical pain. Her murmur on letter B. Her murmur was present bilaterally. The oxygen saturation was 92%, and she had a little bit of shortness of breath. On C, she was hemodynamically stable. Her pulses were full. She had Can we go on?
Yeah, we can.
Someone needed to mute.
Yeah, we just had some mics open.
Okay.
Sorry, Dr. Jade, just go ahead, please.
Her pulses were full. She had a closed pelvis. Fast was negative and E-fast was positive. Her Glasgow was 15. Isochoric pupils, and they were photoregents. Letter E, she had a wound in the back of her left thigh, in the left elbow, and she had a subgaleal bruise in the frontal region of her skull. So, what would you do next, receiving this patient?
Excellent. Thank you very much for this initial presentation. So I'm going to call some of the colleagues to make their comments. Let's start with Dr. Untracht. Are you able to start, Dr. Untracht?
Yes. First, I'd like to ask, what does LMRF mean?
It's her name.
Oh, LMR, the initials. Okay, very good.
Her initials.
Yes, right. Thank you. So a stable patient who run over by a car. So what part of when you say run over, did the wheel go over her body? Did the car run over her? Or was she knocked down? Or
she didn't specify to us. She didn't say.
Okay, so stable patient, and I would put in a couple of IVs, have some blood available for type and cross, and some baseline studies. And I would do the full, it's totally stable, the full exam.
Dr. Untracht. I'm sorry, you were muted. Yeah.
Sorry, I was muted. Yeah, I'm sorry.
No problem.
Yeah.
Muted. Sorry.
Yeah, so stable patient. So I would put in 2 IVs, send some blood to the lab. You said that the E-fast was positive, but the fast was negative, so presumably thoracic trauma. So I would start with a chest X-ray and also a pelvic X-ray, given the nature of the injury, despite pelvis being closed in physical exam, and then see the nature of the injury to the chest, whether she needs a chest tube. If there's any doubt, she can certainly have to be taken to the CT scan, but I would start with those studies, given her stable nature.
Perfect. Thank you very much. Dr. Jade, just for clarification before the next comments, you said that EFAS was positive, but there was no free fluid inside the belly. So what do you mean with EFAS positive? Was it pneumothorax? Was it hemothorax? What was it? Jade? You're muted as well. So while she's preparing to answer, let me call one of the colleagues.
Can you listen now?
Yeah, now we can hear you.
Sorry. So on EFAS, she had on the right side, she had an hemothorax.
Okay, perfect. Thank you very much. So, Dr. Kassim, do you want to comment this part of the case?
Good morning. I regret to say the sound quality was not really that great, so I had difficulty in understanding presentation. So I have to go by what questions Dr. Untrak asked, and then come to certain conclusion what I think about this case. So the question I have is, you couldn't tell us what part of the car ran over her, but there must be some telltale sign, such as tri-track mark, tire track mark, or some part of the garment that she was wearing gave us some clue how she was run over. And that is an important thing to observe. And you got to do a thorough physical examination of the patient when she comes to the trauma bay to determine the nature of the injury that she may have sustained. So she is relatively stable, and the only thing that you are telling us is that EFAS was positive on the right side, and a chest X-ray would be very, very helpful to see the configuration of the right lung, and so that you can also determine whether a chest tube would be of any use to this patient. Most likely it would be, and I would at least get ready to insert a chest tube at the appropriate time. She has a wound in the back of the thigh, and that makes me think whether there is any chance of she having dislocated or injury to the left knee joint, and one should be alerted for that to make sure so at least you are aware, and there are vessels in the back of the knee joint, and they may have been injured as well. So you need to do a thorough arterial examination, including the ankle brachial index. There is a little bit of subclavial bruising in the head. You may have had some head injury, which will become manifest itself later on, but you should be aware of that. So all in all, she is a very stable patient, and like Dr. Untrak said, you get your IV placed, don't give her too much fluid, and then arrange for the have to have a chest X-ray in the trauma bay, and perhaps you may want to do a head-to-toe CT scan to see what you can determine and then you will go from there. Thank you.
Perfect. Thank you very much. I see Dr. Hochman as well is here in the meeting. Do you wanna comment any additional
No,
ideas?
I have the same problem that Dr. Kasim. There were too many open microphones, and I couldn't understand too much at the beginning. So I will continue to follow, and hopefully I can catch up.
Perfect, no problem. So we have a question in the chat. Dr. Aman is asking what murmur was present. Can you please elaborate? Actually, this bilateral breath sounds that are depicted here in the screen, not a heart murmur that she disclosed. So Dr. Jade, I think you can continue, and we're going to call more colleagues in the next questions. Thank you.
Okay, can I move on? About the question, her murmur was preserved. She didn't had other sounds on her chest, I forgot the word. But it was okay. And so moving on, as the patient was hemodynamically stable, she was taken to the CT scans. As was said, we did and full head to toe CT scans. I'm going to put here only those that are important to the case. And then on her chest CT, let me put here. It's not, just 1 minute. It's not playing. I'm going to do something.
No problem, no problem. So while Dr. Jade is getting the CT scan ready, any other comments from the colleagues that are watching? Do you have any other ideas what to do in this situation? You are free to raise your hand and just make your comments. Dr. Collet, I see that you are already also in the meeting. Do you want to add anything in this part of the case?
Carlos, I have some questions about some problems. You have injuries on the left side. She says that she has there's something interesting because injuries on the left and the FS positive on the right side. The hemodynamical stable patient is, I don't know what the parameter is it. Systolic pressure, cardiac rate is very important because hemodynamically stable, anyone can be stable with in shock. Okay, so I think you need the parameters to see what's happened with the patient. And the other problem I can see that in this patient, I believe that patients need to go to see X-ray, pelvic X-ray, and have two venous access. Put the patients is the saturation of the patients is 92%, but she was I don't know if she's receiving or not receiving oxygen supplementation. Sometimes these patients need oxygen supplementation, and I think it's very important. And then if the patient continues stable, the systolic pressure is normal, or the cardiac rate is normal, these patients can go to CT and of full body CT because she has the machine of injury is very great. Okay, That's my comments.
Perfect, thank you. So I think all the panelists agree that that the patient, if stable, patient was going to go to the CT scan. So that I think that's what the team at Brasilia did. So Jade, you are free to continue the case, please.
Okay, so just answering, her heart rate was 65 per minute, and then her pressure, we didn't have the first one right when she arrived, but her right heart rate was that. And then the images we have now, I'm going to play. And passing to the lungs window. Next one. So these were the first chest images. And we had a small hemothorax on the right, and it came with a blocked rupture of the anterior wall of her aorta stem, forming an pseudoaneurysm. It was associated with edema and a small volume of blood on her mediastinum. And it had a mass on the left hemithorax, suggesting diaphragmatic hernia. So it had an stomach herniation. And moving on to her abdomen CT. So it was described with a small amount of blood on her retroperitoneum, mainly close to the infrarenal portion of the vena cava, with no signs of active bleeding. So the question, what would you do next?
Perfect. Very interesting case. So a very, very high energy trauma. So let's move on with the comments. Let me see, Dr. Kassim, do you want to make some comments in this segment of the case? What would you do?
So to summarize, there are 3 suspected injuries. Please correct me if I'm wrong. You have an aortic injury with no active bleeding, otherwise you'd be dead. So you have an aortic injury and you have a diaphragmatic injury, and there is a suspect something happening near the infrarenal vena cava, most likely extravena caval injury, causing some blood pooling in that area. And so far, we have not determined she has any intestinal perforation or any solid organ injury in the peritoneal cavity, interperitoneal or extraperitoneal at this moment. Am I correct?
Yes. Yes.
Okay. So when you have this type of injury, you have to determine which of these injuries is life-threatening so that you can prevent the demise of the patient in the next few minutes to a few hours or whatever it is. In trauma, the dictum is you stop the bleed first. And if there was active bleeding going on in the intra-abdominal cavity or below the diaphragm, you need to attend to that first, no matter what the aortogram shows or CT scan shows with reference to the aortic injury. Because most aortic injury, if it is significant one, the patient is dead before they arrive to your department, or as soon as they arrive, they're dead. And even a thin layer of the aortic tissue can keep the patient alive for several hours. But again, you need to stop the bleed. If there is anything bleeding going on below the diaphragm, you need to attend to that first. This patient does indeed have a ruptured diaphragm, and that can wait as well. So you don't have to deal with this because it is nothing very urgent. You know, patients can live with a ruptured diaphragm for days, weeks, months, years even, as long as they are not having any respiratory compromise. So it comes down to the aortic injury. So you need to have this patient immediately transferred, if you don't have the facility in your hospital, to a unit where they can do endovascular repair or endovascular treatment for the aortic injury as soon as possible. And the rest all can wait. That is my opinion. And I would like to hear what others would do. Thank you.
Excellent. Thank you very much, Dr. Kassim. Dr. Untracht, do you have a different opinion? Would you agree with the endovascular repair of the aortic or open surgery? What would you do?
Yeah, in general, yes. I couldn't see on the CAT scan where the pseudoaneurysm was, but you said at the isthmus. Do you mean the ligamentum arteriosum? Was it descending aorta? And exactly where was it? If I can ask.
It was an isthmus. On her isthmus.
Yeah, in the isthmus, right?
Yes.
It's there, yeah. Right next to the arrow, Dr. Untracht.
The arrow.
There.
Okay. All right. So okay. So arrow. I don't see an arrow, but but if it's right there.
Went away.
Okay. The arrow, the ascending aorta. The ascending aorta. Okay. All right. Ascending aorta. So that complicates things. Am I right? It's the ascending aorta. So, right. I was going to say that, I agree that, the first option would be send her to a place where if they can repair that endovascularly, although in that location, I'm not sure, but, and then if it can't be repaired endovascularly, then she'd likely need open surgery for it, and if it's the ascending aorta, it would need to be. It looks like it would need to be done through a median sternotomy. So that would take first priority, and then the hernia can be, as Dr. Kassim said, the hernia can be fixed semi-urgently afterwards, either through the abdomen or the chest. If the injury to the aorta were in the descending aorta, and there was no option for endovascular repair, even with transfer, then I would say, okay, take her to the OR, do a left posterolateral thoracotomy, and then reduce the hernia, repair the diaphragm, and then deal with the pseudoaneurysm using conventional open techniques. So, but I would pay attention to the aortic injury urgently.
The aorta first, right?
Yeah.
Okay, perfect. So let me see. So I see that Dr. Ginsburg is also here. Dr. Ginsburg, would you treat it the same way that they did in Miami, or would you do anything different? Are you concerned about the diaphragmatic hernia in this moment, or should we focus on the aortic injury as well?
First of all, you've got the stomach inside the chest, so I'm concerned of ischemia to the stomach. But like the Utrecht and Kasim said, first thing we got to take care of right here is that aortic injury. The vena cava injury, if there is one, I think can be left alone at this time. Retroperitoneal, retrohepatic, it could be retrohepatic, and those can heal on their own. But I would get my cardiothoracic surgeons involved in case you can't land, as Dr. Utrecht said, if you can't land a stent, because that's pretty proximal. And I'd be concerned with the coronary ostia, where it will have to be done open. And if it has to be done open, I would hand this off to my cardiac surgeons to deal with. And then I would also then probably just do a ELAP just to make sure there's nothing else going on that wasn't picked up, like ischemic bowel that's in there or whatever, just to pull the stomach down and repair it after the surgery was, or the endovascular technique was done to the proximal aorta.
Excellent, thank you. So I think we can move on, and we will ask for further opinion.
Can I make a comment?
Yeah, sure, Dr. Hoffman.
So this is kind of like a nightmarish scenario what you have, because as Dr. Untrach already pointed out, this is an ascending aorta. I am unaware that this can be repaired endovascularly. Normally you repair endovascularly the distal one. The ascending one, I am not, maybe it's done, I never heard of it. So this has to be done open. And this patient needs to go in cardiopulmonary bypass. So normally you will put this patient in cardiopulmonary bypass through the groin, except that this patient has an IVC injury. So this is where the whole situation becomes a little bit tricky. So yes, cardiac surgery, as Dr. Ginsburg already pointed out, has to be involved. But this is a case that suddenly the options are all bad options. Yeah, the first thing to repair will be the aorta, median sternotomy. Maybe you can see the stomach through the pleura and push it down that way. And I will, normally in those cases, we try to fix the heart, the aorta in this case, close the chest, and after that go to the abdomen to avoid the cross-contamination. Sometimes that is unavoidable if the patient has a perforated discus. But this will be a very difficult case to decide the approach. And I will be very interested to see what they did, because I think that's the reason probably this is being presented, because it's probably a very difficult approach. Thank you.
Yeah, for sure. So there's a question on from the audience, and I'm going to ask Dr. Untrach to answer this question if possible. So Dr. Aman is asking, can we place an intercostal chest drain tube and do a close monitoring? Since the patient is vitally stable, proximal aorta repair may increase the morbidity. So could we do this with a chest drain and just observation?
Well, I'm not sure which side the chest drain. You can put a chest drain on the right side, but it's probably not necessary. It's a very small hemothorax. I certainly wouldn't on the left side, because that's likely to cause a perforation of the the herniated stomach. That'd be hard to avoid. You can try to put it anteriorly, but even then, there's no indication for it. There's no need for it in any case. And then that type of aortic injury, that's very atypical. Most auto accidents, if it's a driver in a car that's unrestrained, it's at the ligamentum arteriosum. This is proximal, so it has all the problems that Dr. Hockman mentioned, and and you also have to worry about dissection, pseudoaneurysm, but a dissection that will then impair the coronary arteries potentially. So I think really, in this case, I would proceed directly to getting the cardiac surgeons involved. Let them deal with the aneurysm.
Perfect. Thank you very much. Dr. Jade, you can proceed, please.
Okay, so I'm going to pass the images. So, seeing the CT scan results, the patient was monitored on our emergency room, and she remained hemodynamically stable without any abdominal symptoms. The vascular surgery team was called and immediately indicated an endovascular approach. So, on our emergency room, as was said, she was monitored and oxygen supply was offered. The patient was exposed, and we had our venous access and the labs. We collected her labs. So the endovascular approach, they did an femoral access, and the angiography confirmed the injury on the aorta, forming an pseudoaneurysm. So it was confirmed, as was seen in the CT scan, and endoprothesis was implanted. So we have the images. I'll play it again.
But this is a distal aortic injury, based where they put the stent, not an ascending aorta.
It never was an ascending aortic injury to begin with. It was misread as ascending.
So, can we move on?
Yeah, you can.
So after the endovascular approach, a new CT scan was done to reevaluate the amount of retroperitoneal blood that was described on her first abdomen CT and the findings. We excluded an active bleeding on her retroperitoneum. We excluded urologic injuries, and the hemothorax on the right had increased. So this is the second CT, chest CT.
By the way, just a comment, while your endovascular team was there, I might have, I'm not saying I would have, but I might have thought of sticking them in the femoral vein on the right side and shooting a venogram to elucidate the vena cava, just to see, get information, because you can always stick stents in the cava also if it's a massive injury.
Yeah, great comment. Thanks.
Great idea.
So we went to the open approach exploratory laparotomy that was indicated to correct the diaphragmatic hernia on the left. So the diaphragmatic injury was measured 4 inches and was sutured with polyester 5.0, and it contained stomach and great omentum with no signs of ischemia or necrosis. We had an hematoma on the abdominal wall, on the left iliac fossa, and we had no active bleeding on the retroperitoneum. This is an image. And we've proceeded with a bilateral thoracostomy with tubular drain 32 French. This is the X-ray after the chest was drained. So after the surgery, the patient was hemodynamically stable and referred to the ICU. She was sent to the ward on the 3rd post-op day. Her diet was released on the 1st post-op day without intercurrences. Prophylactic anticoagulation started on the 2nd post-op. And on this image here, we can see on the lungs apexes, we have some image that was strange. So we repeated, we realized a new CT scan. So it was done after the left drain was removed on the 4th post-op. This is the image. So the next day, we took off this other drain that was still there. The right chest drain was removed, and she received an hospital discharge on the 5th post-op.
Okay, great. Let me just have another round of comments from the panelists here. So, Dr. Untracht, how would you proceed with the retroperitoneal bleeding? Would you agree with Dr. Ginsburg's idea of doing a venous contrast study, or would you before the surgery, or would you explore it during the surgery because of the risk of IVC injury?
Yes, so the vena cavagram is absolutely fine. Also, that last CT, there's contrast, so I think you can image the IVC in the contrast phase, and then technically, I guess this would be considered a zone 1 hematoma. So, by strict construction, you normally would explore them, but if the vena cava proves to be uninjured either by cavagram or on the CT, then I would look at it during the laparotomy. Certainly the belly's open, have a look. I don't know that I would spend a lot of time exposing the retroperitoneum, but if everything looks okay, I would leave it. It's not expanding, and treat it like blunt injury. Typical blunt injury in the retroperitoneum. Right, so that's what I would do for in this case.
Great, thank you, Dr. Hoffman. I have a question as well, so you can give us your tips. So, what kind of tips would you give for for the surgeons who are dealing with a diaphragmatic tear as big as this one. So what intraoperative tips or techniques would you give to someone to make sure you're having the most suitable suturing and the most suitable treatment in this case? Oh, you're muted, Dr. Hoffman.
I don't have any particular thing. The classical teaching is that this is repair with interrupted, non-absorbable sutures. And during the course of these years, we repair many times this with running suture with PDS, which is absorbable, and they all work okay because it's muscle. It's like when we close the abdominal wall. So I don't have any particular thing, except the diaphragm is very pliable. Usually you have good edges, so you take big bites and you close it, and usually it doesn't give problems. Sometimes when it gets close to the edges, particularly near the aorta, if the injury involves near the aorta, the pillars of the diaphragm near the aorta or the esophagus, sometimes the posterior part is difficult to suture and may have a recurrence, but it's really not too much. It's not too common. So really it's, I don't have too much to add to whatever was said already. I will add to what Dr. Untes already said, that I would have done, as Dr. Ginsburg said, the venogram, just to make sure. If it's not actively bleeding, I probably wouldn't touch. But that's the only thing I have to add. I think this case was managed by the book, so it's difficult to add when everything was done right.
Perfect, thank you. Before we move on with the comments, Dr. Jade, there's a question from Dr. Rafael in the chat. He's asking, did the prosthesis cover the carotid and the subclavian vessels?
The subclavian vessel, yes.
And the patient did not have any problems with that, right?
No. She didn't present any symptoms associated.
Perfect, thanks. Dr. Kassim, any additional comments, any additional things to do in the surgery? Would you do anything different?
The brilliance of Dr. Ginsburg is so obvious with this case. Only a master surgeon like him can think something with it. You see, in surgery, you should always be thinking about how can I solve the problem without having to cut the patient open to look at it. And if you can get a venogram and determine everything looks okay, you don't have to go and mess around in that area. Just go and fix your diaphragm and get out as quickly as possible. I think that was a brilliant idea from Dr. Ginsburg. And quite often we as surgeons, we don't think like that. You know, we, in the excitement of the other injuries and scenario that we are being faced with, we are always thinking towards, you know, cutting the patient open and looking at it, rather than getting something done without cutting the patient and getting the same answer, so that you don't have to deal with it if it looks okay. I think Dr. Ginsburg's idea was a very good idea, and it's something that I should remember. More than likely, I'll forget as years go by. But I think the people who treated this patient did a fantastic job, and everything they did just worked out for them, and the patient came through very nicely. To be able to get discharged after a massive injury like this on the 5th day is a remarkable thing. Thank you.
Great, thank you very much. Dr. Ginsburg, since you gave the idea of the venogram, would you do anything different if the venogram was positive during the surgery? What would you do?
I would call Dr. Kassim and Dr. Hoffman to deal with it, and Dr. Utrecht. No, obviously if it was a very large injury, with a huge pseudoaneurysm. I don't have the guts of these other partners of mine here in the chat and Dr. Colette, and I probably would tell them to throw a stent, since the guy's already had, you know, 2 major injuries being fixed, and I'd rather not have to, you know, get and open up and try to fix it directly. So there are nice large venous stents that can be placed. But in that case, I'd like to hear from the others. If there was, let's say, a very large, you know, IVC pseudoaneurysm, would you put a stent? Would you just leave it alone and watch it and see if it endothelializes? I'd like to hear from Dr. Colette also. I think he was on this talk, or any of my partners.
Sure. So let's start with Dr. Collet, who was called namely here in the meeting. Dr. Collet, are you there? Could you comment on the treatment of this possible vena cava injury that was raised upon?
Yes. Carlos, I have some comments with this case. If you make heteropatic vena cava injury is tamponated, you can see resorption on the CT, but the vena cava or pseudoaneurysm of vena cava, you can wait. Usually is diminished along the time, and do not put your hand in this position of the trauma blood of the heteropatic vena cava. When we try to explore this vena cava,
Yeah, I think Dr. Collet got disconnected.
Heteropatic vena cava, you can tamponate the hematoma. You sometimes don't have time to repair or other procedures to do this, but in the
Yeah, I think he got disconnected now. Okay, so Dr. Kassim, would you agree with the approach? Would you do a stent or would you do an open repair?
I think open repair.
I think 1 second before you go on. I think the real question is not so much the open repair is, if you did have a pseudoaneurysm, I'd like to hear from the others if they've had experience, because we've left, you know,
aorta injury and abdominal injury or transdiaphragmatic injury. In this situation, sometimes you don't have angioembolization or angio treatment to put endoprothesis in patients. So in this situation, sometimes you have to treat the patients. You have to fix the abdominal injuries, and then you transfer the patient to where have endovascular surgery. You don't have to wait the endovascular surgery to treat abdominal injuries in this situation. Sometimes the stomach can be a necrosis and maybe a complication injuries, and you lose the patient. If you have a tamponate injury of the aorta, you can manutention the patient with hypotension, and then you can treat the injuries that aggravate the patient, and you put endovascular. If endovascular treatment with you, and there's no problem, but you have to think about all the several services don't have endovascular services, so we have to transfer the patient, and the transferation is not quickly. So you have to think about, if you have surgery, you have to treat to fix the injuries, and then you can transfer the patient to treat endovascular injuries in the aorta. So it's very important. For the inferior vena cava injuries, if it's tamponated, you don't have to explore. If it's not tamponated, go to the peritoneum, you have to explore. There is only the way.
Great, thank you.
And
Thank you, Dr. Collet. So, Dr. Ginsburg, you were
once again, my question to all of you, since these are not so common, if you have a large, I mean, a 1 centimeter or 2 centimeter pseudoaneurysm of the cava, I'm going to leave alone. But let's say you had a big rip to go around the room, and including Dr. Colette. You know, I've never put a cable stent, but it is described. And that's what I wanted to sort of ask. Have any of you had an experience of that type of injury where you've actually stented it? And that's my question. You know, from the outside, not from the inside, you know, through the femoral vein.
Yeah, yeah. Okay, so I'll give a round here. I have no experience with
Or leave it
staining
alone,
cables.
or leave it alone.
Yeah. Okay, so Dr. Kassim, do you have any experience with that?
I personally have not done that, but I have seen somebody do that in one of the hospitals, and they presented the case, and they put a stent in the intravena cava, and the patient seemed to have done very well. And at that same talk, they also talked about that if you don't have stent available, and they would just leave it alone, because the hematoma surrounding the area compresses everything, and what happens in the long run is some type of covering occurs, or endothelialization occurs, and then over a month or years, the hematoma gets reabsorbed, and patients seem to have done well.
Perfect, thank you. Dr. Hochman, do you have any experience with stenting the vena cava?
No, I don't. I don't have any experience. If I see one and the patient is not bleeding, I would probably consult vascular surgery and ask if they have done it, but I haven't seen that being done. So no, I don't have anything. If I don't have a stent and the patient is asymptomatic, I certainly would leave it alone. If it's behind the liver and the retropathic IVC, I would not touch that patient with the proverbial 10-foot pole. And if not, many times when I operated in this type of retroperitoneal hematoma with a suspicion of a vena cava injury, it's usually something else that is injured, not the IVC. It's either the renal vein or the gonadal vein or one of the lumbar veins, and they bleed a lot. If they are bleeding, you need to explore, but the IVC is set for penetrating injuries. Although I remember one case when I was at Yale, a partner of mine that I went to help him, the patient had a transection of the IVC from a blunt traumatic injury that we ligated the IVC at that time. But those cases, you have no option. You have to go in. If they are not bleeding, we'll probably leave them alone. It's very difficult to make a patient who's doing fine to make that patient do better.
Yeah, these are the difficult cases. Dr. Untracht, do you have any experience with that? Do you have any additional comments?
Thank you, sir.
Dr. Untracht?
Did you just call on me, sir?
Yeah. Do you have any experience with these cases like this?
Yeah, my screen just froze, and it just unfroze just as you called on me. I don't have any experience with stenting the vena cava, and I would imagine that, you know, as Dr. Hochman said, a tear of the IVC with blunt injury must be exceedingly rare. I don't know if anyone has published a series, but I'm sure it must be very, very rare. And then with penetrating trauma, there's no containing the hemorrhage. You have to deal with it. In that case, if the stent can be placed quickly, I think that's fine. Otherwise, you know, if you have to do it open, you're in the belly, you can get control and repair it or patch it, whatever. But I think if a stent is available, that would be preferable.
Okay, perfect. Awesome. Thank you very much for your participation. We're heading to 2 o'clock here in Brazil. I wanted to thank everyone for being here, and I'm going to call Dr. Mardos. He wants to
Antonio, it's icky. and the group, there's two more comments I want to make.
Yeah.
And one is this patient had an increased hemothorax on the right side, correct? On the repeat CT. So if I were them, I would re-CT this patient in a couple of weeks when inflammation, everything clears up, to take a look at that right-sided IVC area, just to see what has formed there or not, just in case. I tend to be, I'd like to err on the side of safety, that there isn't something actually there. And then the second thing, I actually think the interesting part of the discussion was getting what would you do if it was a proximal aortic injury? And the discussion we had with everyone of getting cardiothoracic involved, because you got those coronary ostia, and I don't think an endovascular stent, as Dr. Hochman, Dr. Kasim, the rest, discussed. So those were my only two comments. A very good case.
where? Eh?
Antonio?
Yes, I'm here. Hello?
Yeah.
Yes, thank you everybody for the nice work. Wellington and his group, again, a nice presentation. We also have good case.
5.
Dr. Menegoso, excellent moderation. Thank you for all the panelists participating. The idea is that we're going to start rotating the moderators to give opportunity to a lot of people to moderate leadership and more people to be the panelists as well.
Right.
And in September, during the WST meeting, we're going to have a live session to launch the joint meeting with WST. And this, so every second Monday of the month, we're going to have an international meeting as well with WST. Thank you, everybody.
Quick question: is anyone coming to the ACS meeting in October in Boston?
Hello, I think I was muted, right? So Dr. Kasim, yes, we should be in WST and ACS. Actually, at the WST meeting, we're going to have a lunch section where we're going to introduce the new meeting they're going to have with PTS and WST. So every second month of the month, you're going to have a joint meeting with WST and PTS for this meeting. All the other two meetings are going to be the same format. The idea is to have different moderators for every meeting, and so we can have more people showing the leadership and putting these on our CVs. And looking forward for continue this meeting that has been 13 years already. Please, next week, Dr. Alon Schwartz from Israel are going to present a case. Please contact Liliana to put your cases in the schedule and for the upcoming weeks and months. Okay. Thank you very much.
You have the CME code for this session?
Yes, it's on the chat, Dr. Track.
Thank you.
Bye. Thank you very much for being here.
Thank you all. Thank you.
Bye-bye.
Bye-bye.